When we talk about treatment of atrial fibrillation, really we separate out two different things. We separate needing to treat to decrease a patient's risk of stroke, but we also sometimes treat the symptoms of atrial fibrillation.
We treat the risk for stroke with anticoagulants. Those are also known as blood thinners. The most common blood thinner that was used for years was warfarin or Coumadin. Now we have newer medicines that we call the NOACs. And those medicines, compared to Coumadin, show no difference in blood thinning, and there may be a lower risk for bleeding on some of those medicines.
So there are two main strategies that we use in patients that have symptoms from atrial fibrillation. Rhythm control refers to the fact that we want to get them out of the irregular rhythm of atrial fibrillation. Rate control means that we will accept the fact that they stay in atrial fibrillation. Their heart will still be irregular, but we will lower their heart rate so that the heart rate isn't so fast that they have symptoms.
There are some medicines that we can use to control heart rhythm.
Your doctor may decide in conjunction with you that they would rather rate control you, meaning get your heart rate at a particular level. And they could do that with medications called beta blockers or calcium channel blockers, for example. Or your doctor may decide, I want to actually get you out of this atrial fibrillation. They may suggest you have something called a cardioversion. Cardioversion is an electrical shock.
In most cases, before we do a cardioversion, we want to make sure that we're not missing any clots that are already sitting in the top part of the heart. We use something called a transesophageal echocardiogram, which is a special kind of echocardiogram where a patient swallows a camera, similar to an endoscopy, where the camera goes behind the heart and shows us all the places where those clots might be hiding.
If there's no clot, then we can safely perform the cardioversion, which is the shock. Our hope is that with that shock there, you go back into normal rhythm. If you have atrial fibrillation, it likely means that you're going to have it again in the future. And sometimes the suggestion may be, how about we try to get rid of it altogether? And that's something called an ablation, where we're able to ultimately go into the heart with catheters, and then we burn away the area where we think the atrial fibrillation is coming from.
How we treat atrial fibrillation is a very individualized decision that needs to be done directly with a patient and their cardiologist, because every patient comes to the table with a different set of risk factors and a different story behind their atrial fibrillation, and we try to individualize based on their profile.